explosive introduction. Thank you, Dr. Bansi and the entire team, DiaObecon. And I have, following me, a set of exceptional speakers who are going to take you through the entire journey of insulin. And I'm just going to do the start. So I'm going to be the first batter, the opener rather, and I'll take you back to those old days and the gold standard in basal insulin in the form of U100 glargine. So I think you had been using U100 glargines ever since you started your clinical practice, and so there's nothing much to talk except for the fact that I want to share some real-world experiences with using U100 glargine. So this is a landmark trial, and I was a part of the landmark trial, and probably that is one of the reasons why I'm here speaking to you today. So it's one of the largest, trials that was done. It was longitudinal, prospective, observational, real-world study. And what came out was that almost 63% of the type 2DM patients were having an HbA1c of more than 7%. And this is not uncommon, and this, if you look at the ICMR India database, it's the numbers are very similar. 57% of the type 2 diabetic patients were on more than 3 OADs, and this is a common conversation that happens every time the patient comes to you. The patient would request that don't put me on injectables, add another OHA, and you want to comply to the request of the patient, and the number of OHs keep increasing. So participants were obese. Almost 66% had a BMI of more than 27.2%, and 21% patient had micro or some form of macrovascular complications. So this was me presenting landmark at ADA last year. And one thing that was very interesting to see is that, if you look at the number of participants who were presenting to you with either a macro or a microvascular complication, and if you look at the percentages, it's very similar whether you go north, east, south or west. But there is something which is glaring right in front of your face, and I was very happy to see the numbers. Proportion of study participants achieving a A1C of less than 7% at 3 years seems to be better in east for some reason, more than 50%. So anyone from the east, a big clap to you. And I think it's very similar. The numbers are very similar whether you go north, west or south. It's close to about 30%. So I have no idea what the reason is, but I'm very happy because I belong to east. Now, if you look at the micro as well as the macrovascular complications and the glycemic trend that happens, whether you compare the metro versus non-metro, the difference is minimal. There's not much of difference, really, so as to say. Complications and glycemic control, 70.2% of the participants with macro and 70.3% with microvascular complications had uncontrolled diabetes, meaning having an A1C of more than 7%. And the idea is to break this vicious cycle, and uncontrolled glycemia obviously leads on to complications, and we know this from landmark trials starting from UK PDS. We know about the bad glycemic legacy, and complications make glycemic control even harder. So it's an ongoing vicious cycle that we come across. Regional trends of basal insulin usage, again, remains pretty dismal. If you look at the last 3 years at baseline, and then obviously at the end of 3 years also, it doesn't improve too much. Slightly better again if you look at the data coming in from the east, going from 11% to about 30%. I think basal insulin is something that physicians feel comfortable. They get on board with the basal insulin faster because it's once a day. It's easier to convince the patient to get started rather than 2 breaks a day with the premix insulin. And obviously, I think the physicians feel more comfortable when it comes to up titrating the dose with the basal insulin. But in spite of that, we know for sure that although you initiate them on basal insulin, up titration and achieving the target fasting still remains pretty dismal. So despite no additional benefit in glycemic control beyond 3 OADs, the initiation of insulin is still delayed. And this as we said, is a common conversation that happens between you and the patient, because every time the same request comes in from the patient saying that, Doctor Saab, थोड़ा और हम कोशिश कर लेते हैं, इस बार मैं कुछ गलत खा लिया, इस बार कुछ गलत कर लिया, आप देख लो मैं कंट्रोल में लेके आऊंगा, इस बार ही मत दीजिए, दूसरा कुछ OH दे दीजिए, जो भी मिलेगा. And we have now all the combinations under the sun available with us. Some are rational fixed dose combinations, some are not, but you have an entire gamut, entire armamentarium of OHs available with us, and so the burden of OH keeps increasing without much improvement in the A1C, so as to say. So we have to, tell ourselves, we have to convince ourselves that once we go beyond 3 OHs and the A1C is not coming down to the control levels or the target levels that we set for the patient, we need to get on board with some form of injectable. Need for timely insulin initiation. So we can't emphasize enough, and the recommendations that come in from ADA or the ADASD guidelines saying that basal insulin is the most convenient one to start off with, for the reasons that we said. It's a 1 prick a day, and it's easier to up-titrate and get the fasting under control. And I'll show you a slide where we talk about fixed fasting first. So 4 crucial factors significantly influence the selection of appropriate insulin. Efficacy. So how is the glycemic control? I think any insulin for that matter is equally efficacious. It doesn't matter. The only concern with the basal insulin is that once you get the fasting to the targets that you want, if the prandials still remain high, you need to consider having something else which would look after the prandial sugar level. So either you can bring in a prandial insulin, or you can bring in a GLP-1, or something else like an AGI that will bring the prandials down to the control levels. And this is a big challenge that comes with the Indian population, because we know that the carbohydrate content of each meal remains very, very high. Safety-wise, so I think the only difference that are there between the first generation and the second generation insulins are the overall and nocturnal hypoglycemia. And convenience-wise, I think any basal insulin can be given once a day, and that is very convenient for the patient, and it can be given at their choice of time. So usually we use it at bedtime for convenience, and also the cost-wise is something that we have to consider when we are considering a therapy for the Indian population. So let's go to the efficacy first. We were talking about fixed fasting first, and look at this diagram. So if you bring down the fasting, automatically what happens is that the prandial sugar also comes down by a significant margin, and then most of the time you see that if you do a CGM-based study or multiple SMBGs, you'll probably see that it's falling within a range for most of the times. So sometimes you might need to use a prandial insulin with the largest meal of the day as a basal plus, or you can use a GLP-1 to look after the prandial sugars. Now, U100 glargine significantly improves the glycemic parameters in insulin-naive type 2 diabetes patients, and this is a study coming in showing reduction in A1C from the baseline at 3 months and 6 months, and proportion of patients achieving target A1C of less than 7.5%, which is significantly more at 3 months and 6 months. Now with U100 glargine versus human premix, again the challenge is 1 prick versus 2 pricks. Even with that, it seems like if you are fixing the fasting first, you see that there is a 26% greater A1C reduction with U100 glargine as compared to premix. Probably the reason is that patients don't adhere well to 2 pricks a day to start off with, and even if they do, they don't up titrate properly for the fear of hypoglycemia, which is probably lesser with once daily basal insulin. Now U100 glargine versus IDEC-ASP, which is a co-formulation, and you see that obviously you have to consider that in this, if you're having the same number of units, 70% will be the basal component and 30% in the co-formulation will be the prandial component. So obviously you can expect a better fasting control with only basal insulin versus the co-formulation. And this is probably one of the reasons why U100 glargine score over IDEC as when it comes to A1C reduction. So U100 glargine plus OADs with adequate titration can help patients achieve sustained control for more than 2.5 years, and this is the data that has been shown. Now coming to safety. So I think the only concern that remains between first and second generation insulins are overall hypoglycemia and nocturnal hypoglycemia, which seems to be better with the second generation insulins because they have a flatter profile with less variability intraday and interday. So if you consider between IDEC aspirin and a co-formulation with U100 glargine, it seems that U100 glargine required 33% lower insulin dose compared to the co-formulation, and also 11% lower insulin dose requirement was seen with U100 glargine. Low risk of hypoglycemia as well because it only contains the basal component. The prandial component is the one which increases the hypoglycemia risk. So with the co-formulation like IDEC ASP, U100 glargine scores better in 50% lower risk of hypoglycemia. And if you consider confirmed hypoglycemia, again, it seems like the IDEC ASP has higher percentage of confirmed hypoglycemia as compared to U100 glargine. Lower weight gain, again, if you require less number of units, like the basal insulin requirement, we showed it was slightly lower as compared to the premix insulins, and thus you have 35% lower weight gain as compared to IDEC ASP or twice daily premix insulin. Now, so what about safety across the boards in the vulnerable population, like in the elderly individuals? So we have data that it's safe and efficacious in the elderly individuals. It's safe in the hospital settings. It's proven efficacy and safety in diabetic patients with a CKD of 3 and 4 and can be used during pregnancy. And obviously we know the ORIGIN trial, which was one of the landmark cardiovascular outcome trial with insulin, which showed cardiovascular safety. Now when it comes to convenience, we can't emphasize enough that it's a once daily prick, once a day, and it's easy to up titrate. So you can just start with 10 units or you can calculate based on the body weight and then gradually up titrate 2 units every 3 days or 4 units every 7 days as you wish till you get to the target fasting. And what has been seen is that with U100 glargine in place, the quality of life is much better. As compared, so when you're treating patients in Indian subcontinent, you have to take into consideration the cost as well. And you see in here, the innovative glargine, U100 glargine has now become more accessible because of the price drop. So the biosimilars and the originator glargine doesn't, there's not much of a cost difference. And I'm not here to talk to you about the cost. This will be done by the company per se, but just to give you an idea that it's, very similarly priced as compared to the other biosimilar U100 glargine. So there's no reason why you should not be choosing the originator over the others. Now, so most monthly cost of therapy is now lower than human premix as well. So again, many times you fall back on human premix and analog insulins. It seems like the basal insulin is less costly as well. So importance of optimizing basal titration and intensification for key to successful management of glycemic control and adequate titration is to start early and then up titrate to the fasting target that you had set for the patient within the next 12 weeks. So this is very, very vital. So you have to set with the patient and counsel the patient, and usually you can go up by 2 units every 3 days or 4 units every 7 days. This is the usual protocol, but you can customize based on the patient profile. If you feel they are vulnerable to hypoglycemia, then you can take it even more slowly. And for initiation, you can calculate based on the body weight as well, or you can straight away start with 10 units and then gradually move up. But if you feel that there is a lot of insulin resistance or the BMI is very high, you can start with the higher doses as well. Stepwise intensification, as we said, you can add, OAD or a GLP-1 to take care of the prandial insulins as well once the fasting has fallen to place. And then, gradually, the advantages of basal prandial intensification is, so start off with a basal plus. So once your fasting is to control, you take on board a prandial insulin with the largest meal of the day, and then move on to basal plus plus, or a full-on basal bolus, or a basal plus a GLP-1 as you wish. And, the advantages of basal prandial intensification is that it mitigates the prandial excursions, fewer hypoglycemia risk, and it's easy to titrate and in a stepwise manner. So I think this is known to most of you. I would not go into the details of this. Just to summarize again, we are looking into 4 components. One is the efficacy. So any insulin is as efficacious as the other. Basal insulin, the main work is to look after the 24-hour sugar control and also fix the fasting. Convenience is that it's once a day, so easier for you to convince the patient to start on insulin therapy. And safety-wise, we have shown that it's even more, if you consider the safety or overall hypoglycemia risk, it's lesser than the co-formulation like IDEC ASP or twice daily premix insulins. And cost-wise, the originator basal insulin U100 Glargine now costs almost similar or even less than the biosimilar. So you need to consider U100 Glargine, the originator one, over the biosimilars, or even the premix as the initiate as the insulin to begin with. So over the years, U100 Glargine, the originator, remains the gold standard basal insulin therapy in those with type 2 diabetes. So the landmark trial, if you try to do the mnemonic, it says large evidence-based, and then, efficacious, affordable, 22 years of experience. Origin is an original, the cardiovascular outcome trials giving proven cardiovascular safety, and U100 Glargine still remains the gold standard basal insulin. Thank you.